Hi everyone. My name is Mohammed Mouhawi. I'm the head of Morocco SIM, which means the Moroccan Society for Simulation in Healthcare and Innovative Pedagogy. Our slogan is SHINE, and when about talking SHINE, it's about S for Simulation, Healthcare, Innovation, Networking, and Education. I have the great honor and pleasure to introduce this session and decision with a great webinar, and I will hand it over and give directly the floor to Norm McCawy. Norm McCawy, the stage is yours.
Thank you, Professor Mohawi. So good evening, everyone, and welcome to this Shine webinar organized by Morocco SIM under the theme of Simulation, Healthcare, Innovation, Networking, and Education. Tonight, we have the pleasure of hosting an exceptional session titled Pediatric Simulation, Shaping Safe Future. This topic resonates deeply with our mission to improve healthcare, education, and patient safety through high-quality simulation. I'm Dr. Norm Kawi, and I have the honor of moderating this session. We are thrilled to welcome a distinguished guest from the United States, Dr. Callahan Christopher, joining us from Boston. Alors, Dr. Callahan is a combined internist and pediatrician and expert in simulation-based education. Based primarily in Boston, he currently practices adult and pediatric hospital medicine at Mass General Brigham and Boston Children's Hospital, when he is an instructor of medicine at Harvard Medical School. He also serves as a deputy chair of the Center of Transformative Learning Technology, CTLT, at the University of Global Health Equity in Rwanda, when he plays a pivotal role in developing and leading educational programs aimed at enhancing knowledge transfer, clinician performance, patient safety, and more. Dr. Callahan is not only a gifted clinician and educator, but also a researcher whose work focuses on the implementation of innovative simulation pedagogies, expanding access to innovative, effective educational technologies, and examining return on investment in leveraging such technologies in different clinical and educational environments. So this webinar includes a 30-minute presentation followed by 30 minutes of a discussion. Feel free to ask questions anytime in the Q&A box. Please welcome Dr. Callahan Christopher. It's yours. You can start, Chris.
All right. Thank you, Dr. Macau. It's really a pleasure to be here and good evening everyone, or good afternoon if you're not in the European or African time zones. Um I'm going to share my slides. Let's make sure that they are good and then I'll get started here. Can everyone see my slides?
Yes.
All right, let me make it full screen. All right. All good?
Good.
Great. It's my distinct pleasure to be here, to talk with you all today. And I'm not sure if this will take the full 30 minutes. I think I erred on the side of less is more because I always tend to talk for too long, but we'll see. Famous last words, I think. As you mentioned, my name's Christopher Callahan. I am an internist and a pediatrician in Boston primarily, and then I have academic appointments at Harvard and the University of Global Health Equity in Rwanda. I have no financial conflicts of interest to disclose for this talk. The only disclosure I have is that I am both an adult and pediatric generalist. So some of the things I might say may be relevant to not just pediatrics. But I think I'm excited to sort of talk to you all today about simulation as it relates a little bit specifically to pediatrics and sort of shaping safe futures for sort of the future children of our world. So I want to get us started by just talking about a few objectives that I want to cover. One, I want to make sure that I cover sort of talking about the role of simulation in clinical pediatrics. I think that one is self-explanatory. Make sure that we have a shared mental model about the depth and breadth of simulation. So I think what simulation means to different people can define sort of how creatively we think about what we can use simulation for. And so we'll talk a little bit about that, I think. Discuss some use cases of simulation that I've been involved in Rwanda, Zanzibar, and Boston, and then just touch on some areas for future exploration because I think this is a rapidly changing field, and that's obviously very exciting, but also a little bit daunting for some of us in medical education or clinical medicine. So, I think if I assume that most of the folks here have done simulation in some way, are simulation experts in the different settings that they work in, but just to sort of get us all on the same page about some of the things around simulation more broadly that excite us all, I think we can all agree that it's a an amazing transformative tool. That in my mind, this is some of my views of what simulation is so special about, builds trust and confidence amongst clinicians, able to break down barriers and ego between teams, normalizes vulnerability and questioning of the status quo, improves our safe delivery of care and our ability to do that. And I think all some, as we realize more and more some of the applications of sim, it's really an immersive technology that can be used not just by clinicians, but by patients and families and healthcare executives and more to really change the landscape of what we're able to do in healthcare. And so we'll touch on a little bit of that. But I think today, since we're focusing a little bit on pediatrics, I just want to hit on a few of the things that as we think about simulation in pediatrics, I think it's important to think just a little bit about what are some of the highlights of clinical pediatrics that are unique and distinct from adult medicine. Because simulation, I think, as a whole is broadly applicable to adults and pediatrics and internal medicine, surgery. You can use it in any way that you want to, as long as you sort of develop your cases and put the right tools to practice. But I think as we think about pediatric simulation, it's important to recognize some of the dynamics at play and some of the uniquely pediatric clinical situations that we often face. So I think the first thing is just to recognize that we can't really talk about pediatric simulation, especially in a worldwide setting, without talking about maternal fetal outcomes. Um, and I think a large part of that is just given how much of under five mortality or pediatric mortality happens right in that, preterm, early term, right around birth period. I think another thing is just to talk about like the WHO under five mortality top five reasons for pediatric mortality: preterm birth, pneumonia, birth asphyxia, diarrheal disease and dehydration, and malaria. If we're going to be talking about simulation in pediatrics, I think we just need to all be on the same page about what are some of the clinical needles that we need to make sure we're paying attention to. And then I think another really unique aspect of pediatrics is sort of the psychosocial part of it, and the fact that in adult medicine or a lot of different fields, we typically only have one patient, but in pediatrics, usually you always have two. And that we can leverage that in simulation and make sure that we're including parents in all of the simulation that we do, and that we are designing simulations sometimes actually not just for our pediatric patients, but specifically for our parents as well. So I'm going to talk about three different cases of pediatric simulation that I've been involved in. And the first is just my home institution in Rwanda at the University of Global Health Equity. So we have an amazing simulation team there. We currently have a five-person full-time team on the ground there, and they support simulation across our entire 6.5 year medical school program at UGHE. In this picture is Dr. Christian Rikorunga. He's one of our simulation lecturers, and he is sitting with some of our senior MBBS students debriefing after a simulation. And so at UGHE, we really strongly believe that simulation for all fields, but pediatrics is obviously included, should begin early in the educational experience. And that starts at the preclinical years. So students are actually coming into the sim center during their first year of medical school. They're getting exposure to what it means to walk through a case and what they can expect when they come into a high fidelity sim or a skills sim. And that carries on through their junior clerkships, subspecialty clerkships, senior clerkships. And I think the reason that that's so important for us is by the time we get them in their clerkships, and specifically their pediatric clerkships during their third year, we can really hit the ground running and they know what to expect out of the simulation sessions. So the way that we've designed pediatric simulation at UGHE for our medical students primarily is sort of a combination of the ETAT, so the emergency triage assessment and treatment cases that are available on the web, to familiarize students with triage, resuscitation, and recognition of shock and basic resuscitation, as well as a combination of homegrown cases that we've supplemented that with in order to deliver a longitudinal curriculum for them that covers both practical skills that they're going to need during their pediatrics care for their clerkships and beyond, as well as conceptual knowledge. And I think we thought a lot about when we first launched the pediatrics clerkship and we said, what simulation cases should we make sure that we have? We ended up going back to the what are the clinical things that are unique about pediatrics that these students are not going to get in internal medicine or surgery or OB/GYN. And so the things that we ended up choosing to focus on were things like neonatal resuscitation, malnutrition, child abuse, diarrheal disease, dehydration. And you can see how that really lines up with what are some of the under five mortality and why it's so important to think about the sort of epidemiology as we think about how we're designing our simulation experiences. So that's a little bit of a glimpse into UGHE. I want to shift into talking about Tanzania and Zanzibar for a second. So, I have not been personally involved in the Laerdal Global Health Safer Births Initiative, but I think most of you might be familiar with this. If not, I definitely would recommend looking a little bit more into it. This is one of, I think, the most extraordinary initiatives in pediatric simulation or maternal child simulation that we have seen in recent years. And so this was a program that was a combination of Laerdal Global Health, which is a group out of Norway, that's sort of the nonprofit arm of Laerdal, working with initially Haydom Lutheran Hospital in mainland Tanzania. And they rolled out a Safer Births bundle, including a number of different simulators that you're probably all familiar with, but the Mama Birthy, Mama Natalie, Neonatalie, NeoBeat. And they did low dose, high frequency simulation with a group of nurse midwives in a unit to really change the culture of that unit. And I think what we were able to see in there is that but what they were able to prove is that by both empowering nurses and midwives and doing frequent low dose simulations, they were really able to change the way that people were thinking, the way that people were able to think about like bringing their mistakes to the table and forefront about why they made mistakes, and a lot of the things that make simulation so unique. And I think oftentimes when we try and roll out simulation at a level like this, we don't do it at the full level of the unit, right? You might do it aimed at some of the clinicians in the unit, but then you don't include the nurses, or you don't include the midwives, or you just do the nurses, then you don't do the physicians. And so doing this at the unit level really empowered everybody to start changing the way that they were thinking about it. And it became a full unit-wide initiative to try and move the needle on improving outcomes. And they have had extraordinary outcomes. So taking actually some of the lessons learned from this, UGHE was actually asked to come into Zanzibar a couple of years ago to work with the State University of Zanzibar's Health Sciences University, as well as a local NGO called Wajamama, to provide simulation capacity to strengthen the health system there. And so what we're trying to do in Zanzibar is to work with both the university and this NGO to empower nurses, midwives, physicians, clinicians to advance their skill sets and feel more confident in their practice settings in order to do things like improve their ability to titrate Pitocin and decrease postpartum hemorrhage, improve their ability to do assisted vaginal delivery and decrease C-section rates, decrease birth asphyxia rates across the board just by improving the processes of identifying birth labor complications. And we feel like this model of increasing the amount of simulation opportunities, similar to the low dose high, or sorry, the high frequency low dose that they saw on the mainland, doing this in the maternal child health space will hopefully really show some improved outcomes. And then we can start doing this in other clinical areas as well. So we're starting with maternal child health, but the goal would be that this becomes a growing network of simulation champions that can then sort of become simulation champions for other areas of clinical medicine, and hopefully work in collaboration with the Ministry of Health. And so that's a very exciting project we're working on, and very much in its infancy. But so the last area that I want to talk a little bit about is my experience working with simulation at Boston Children's Hospital. And I have to credit most or all of this to Immersive Design Systems, which is the simulation program at Boston Children's Hospital, and my advisor, Dr. Peter Weinstock, who recently transitioned from the head of that program to a new program at Boston Children's called Healthcare Engineering, which looks at simulation like an immersive technology, immersive design at the hospital-wide level. Boston Children's is doing some amazing stuff. I think in addition to a lot of the work that we're doing at UGHE and teaching medical students and residents, and a lot of the work that we're trying to do in Zanzibar, decentralizing simulation, um, they have also made a lot of progress in a couple specific areas that I just wanted to touch on. So one of them is 3D preoperative modeling. And so this is just a picture on the right of an example of all of the pre-op models that the 3D printing lab at Boston Children's Hospital has made. And what they've been able to do is use, CT, MRI, other images to then print 3D models for surgical planning in order to decrease operative times and improve patient outcomes. And so that's just a really cool example of how simulation can be used a little bit more, a little bit more abstractly or a little bit differently than we may all think about it in our day-to-day worlds. They also have an amazing team of designers, and so this is just an empty room that has been transformed into an operating room. They have transformed the back of cars into ambulances. They've been able to do sort of system-wide safety drills and testing, extremely realistic team training across the whole hospital. And most recently, Boston Children's actually just built a multi-million dollar new building. And the simulation center, the immersive design systems, was actually asked to help A/B test all of the design choices before they were actually set into place. So they were able to say, why don't we run this case in this design room and see if it works, and then we'll move things around before we actually spend millions of dollars in actually investing it and installing it into that space. And then the last thing that Children's has done a lot of work on is procedural desensitization. I think this is quite unique, obviously, to pediatrics, but there's no reason it has to be. One of the things is decreasing fear of sedation, right? Any children undergoing anesthesia, this is a huge area of concern, is trying to decrease fear and generally trying not to make the medical experience horrifying for children, because you want them to engage in medical care throughout their life in order to stay healthy. So decreasing fear of sedation, working with child life teams to help patients undergo what they're going to expect for IV placement or even lumbar punctures, and generally working both with patients and parents to improve the experience, because I think a lot of these things can be really traumatizing for parents as well. And so I think that that's an area that's very exciting, and there's more to come there. So I'm realizing I'm going to be talking a little bit less. I'm not going to talk over here, but this is my last slide actually, and it just talks about looking ahead at shaping safe futures. I think I talked mostly about things that we've already started working on, but these are all areas that we are really excited about working on going forward in the next year plus. The first one is decentralization of simulation programming. I think as a theme, what I have seen a lot, and this is not unique to pediatrics specifically, but generally, is simulation ends up in either the medical school or the hospital in a big room with all the equipment in one place, and sometimes it can be hard to access. And I think access to simulation centers is such a crucial part of ensuring that our clinicians can sort of get the practice they need, feel like they are confident in their skill sets. And so one thing we're really working on in Rwanda, as well as the project I mentioned in Zanzibar, is trying to develop mobile simulation carts that we can then deploy in our hospitals or in our clinics, similar to the Safer Births Initiative, but these would be fully enabled with AV solutions to video record, stream onto a web capture, get feedback from mentorship, either locally or globally, in almost real time, and really enable us to do team training in a very flexible way, given that these mobile carts could then be moved after 3 months from one ward to another ward. The clinical equipment on the cart could be switched out while leaving sort of the AV core intact. And so that's one area that I'm very excited about. And I think we're going to be using maternal child health outcomes as our pilot for this when we roll this out in Rwanda over the next year. Another is the integration of extended reality and virtual reality. And so I think this goes along with decentralization a little bit of simulation, given that it's a lot easier to transport a headset than it is to transport five different mannequins. And yet you can, depending on the software you have access to, you can run five different, scenarios with five different types of mannequins in one headset. And so I think as the technology becomes more available, as the different software we have access to becomes better, and as the experience becomes more realistic, I think we're going to see a little bit of a shift from using physical mannequins in all of these scenarios to using more XR VR in order to, enable increased access to these kinds of technologies. And I think we'll probably see similar cases to what we're trying to do already with our in-person mannequins. But I think having the XR VR integration gives us the flexibility to also incorporate both a virtual reality situation and a mixed reality if we wanted to have, physical skills be part of the case, in incorporating both of those technologies at the same time. A third is that I think is really, really exciting, and there's a handful of companies working on this, is AI-enabled real-time feedback. And the biggest, I think the best use case for this right now is installing cameras and microphones and sort of AI recording systems into operating rooms and actually giving surgeons real-time performance feedback sort of right after their cases. So, based on the software would know what case you're doing, and based on everything you say and do and the team communication you have throughout the case and the camera, it can actually see where you're going. It has feeds into the laparoscopy. You can actually get feedback uh, oh, actually you took too long to do this, or this started bleeding and you didn't identify it for 5 minutes. Or the way that you guys communicated, actually you may have missed something based on this. Maybe you got lucky, maybe you didn't. And so I think that sort of feedback is going to really enable us to do a lot more rapid cycle learning with each other and ultimately, hopefully, enable better outcomes with our patients. And then I think the last one is just, and this seems obvious, but I think it's worth saying, is just the upscaling of collaboration for sustainable communities of practice. So I think having more networks like you guys have, or having more networks like a unified simulation network across the continent, is going to be so key as all of these technologies are changing really quickly, as sort of the practice patterns are changing really quickly. The clinical medicine is also changing quickly. The more that we can all be connected and the more that we can share resources and ideas, the better. So all of those things I'm very excited about. Um, I guess I just want to end with acknowledgments. Peter Weinstock, my mentor at Boston Children's Hospital and the Boston Children's Hospital Healthcare and Engineering team, as well as Immersive Design Systems. Ornella Masimbi, who runs our Sim Center at UGHE and the whole Center for Transformative Learning Technologies at UGHE, and then my home institution at Harvard in Boston, the Brigham Division of Global Health Equity. So sorry, I went a little short there, but hopefully we have plenty of time for a fruitful discussion. So thank you.
Thank you, Chris, for that insightful and inspiring presentation. We all agree about what simulation can do for health in global and egos and behavior with children and the team. And I really appreciated your experience in low-income countries, if we can still call them low-income countries. Um, I'm curious to know what was the biggest difficulties, because we are a kind of middle low income country, and for my part, I'm a pediatrician, and we have some difficulties to start. We start, but we don't we don't make it all year. So can you give us some advices to make it continue and to join most people with us?
Yeah. Just to clarify, do you mean for individual programs, or how to ensure that individual
For
people are continuing?
institution programs.
Yeah. I think this is obviously an extremely important question and a challenge that every center has. Um, you know, I think my short answer to that would be always trying to keep in mind what the primary goal of your program is, because I think it's very common and popular among simulation to think that simulation, like a strong simulation program, is is a handful of shiny high fidelity mannequins in a fancy looking room, and if you have that, then you have a good simulation program. And I think a lot of us recognize that that's not the truth. And we can really do a lot with very little in simulation as long as you have a few key champions who really care about it and are passionate about it and understand what the learning experience is actually doing for your learners. And so I'm probably sounding like a broken record to Professor Mohammed because he heard me talk about this at our conference in March. But I just think it's so important to recognize that if you are a clinician, educator, you and you're passionate about simulation and you want to teach simulation, you are, 50% of the way there, and don't let the shiny objects or the fancy equipment get in your way. I think the things that you really need are faculty champions, some space and some basic equipment. But even if it's a CPR mannequin or a dummy or something, you can make up the rest. You can put a fake vital signs monitor on your phone, and you can tell the students to sort of suspend disbelief, and start from there. And ultimately, if you can prove what you're doing is working, it might attract some attention from networks or funders, and then you can sort of build up the next scale of your program. But that would be my first thoughts on that.
Okay, thank you very much.
Yeah.
If someone has any question. So I can ask you another question. You said you talked about starting early in medicine studies, like first year.
Yeah.
We did this year. We started this year, but it's not an evolutive curriculum. We made different activities for the students just to make them join the mindset of simulation. How do you deal for the grown curricula? That means it's the same. It's the same, but with difficulties, different difficulties over the years.
Are you, yeah, so I think it's actually a little bit, so we don't repeat the same cases. I think if what you're asking, are you saying like do we use the same curriculum but just make it harder?
The same, yes. Is
Yeah.
it the same with the different pedagogic objectives?
Yeah. We actually try to make it a little bit different. Um, and so I think the reason is because we really, in order to get simulation time in the early years of the curriculum, we've had to negotiate a lot with our physiology professors and our biochemistry professors. I see Dr. Ornella Masimbi on the call. She has been doing a lot of that negotiation, and we've actually had to work to have them see the benefit of simulation, because a lot of the people who are teaching those programs are actually not clinicians, right? They might be PhDs or masters in science. And so we have taken it upon ourselves to be the voice of let me show you how I can make your course objectives come to life with simulation. And so in trying to accomplish that, we've then had to have our objectives for those preclinical cases be tailored closer to whether it's an anatomy class or a physiology class, some of the course objectives that those courses actually have. So I guess the short answer is we don't just do the same case with increasing level of difficulty, but we do keep in mind what cases we ran early on in the preclinical years so that when they get to pediatrics, we know, oh, they actually already did a pediatric asthma case during their immunology course. And so we can build on that a little bit. So it's sort of both.
Okay, thank you.
Yeah, of course.
Any question?
I see a hand.
I raise my hand, Noor. So,
Mr.
Noor?
Mohawi?
Yeah, yeah. Thank you very much, Chris, for your brilliant lecture. And maybe I want to just ask a question about one specific aspect. I think one of the main challenges that we can encounter in using simulating patients for pediatric scenario. So, in your opinion, how do you address issues like emotional realism and something like ethical boundaries? So, I'm talking about the use of SP in pediatric patients.
Yeah. No, I think that's a really good question. And I have not, I will be totally honest, I don't have almost any experience using SPs in the pediatric setting because I think that it can be a little ethically unclear, and depending on the age of the child, are they really consenting to come and learn from or be part of, a teaching experience? Um, I think that as in like neonatal or infant, maybe it's a little bit different. I think it's like when the babies don't really know if they're being part of medical education. I'm not sure. I think it's definitely a nebulous area that I don't know what the right answer is, and I'm not sure sort of what the consensus literature says about it. Um, but it's not something I think we've really crossed into at UGHE in my experience so far.
Yeah. Um, no, can I add a second question, please?
Yes, of course.
So, Chris, one other aspect in simulation is to find the good people, the good person to convince, and about simulation in pediatrics. So, we know we all know that simulation is widely valuable for education and training. So, my question is, how can we better demonstrate its real-world impact on pediatrics outcomes? By the way, we will be able to convince healthcare systems to invest further in it.
Yeah. Both that's a million-dollar question, both actually and metaphorically, I think. And it's something that I've thought a lot about. I think that we are getting to a point, or we already are at a point where we have to do that because that's what's being demanded of us. Funding streams are really tight, and yet we do recognize that if we can prove clinical benefit, we should be able to get funding because clinical benefit should be cost saving, right? And so if we can show that simulation is actually driving cost saving, that's great. I think one thing that's challenging here is that it's really hard to do. That is a general issue in medical education, right? It is like if you do something in the first year of a medical education curriculum, how are you going to prove that that thing you did in year one of medical school actually improved patient outcomes 6 years later when that person graduated, compared to all of the other interventions that you did during that time? So I think in the medical education or nursing education or any sort of undergraduate education space or formal education space, it's a very challenging thing to make an argument for. Um, I think the way that I'm approaching this right now is actually trying to show effectiveness of simulation in the clinical space using practicing clinicians. And I think that if we can prove that a little bit better and more consistently, then it'll be a little bit more of an obvious answer to invest in that upstream. Whereas I think it's happened a little bit backwards, where like a lot of medical schools have started teaching simulation, but we have not done as good of a job continuing simulation intentionally in the practicing clinician world. And I think it's because people are busy, because simulation centers are expensive and take time to create, and so hospitals just have not had as much time to invest in that as medical schools have. But one of the real goals of like the simulation cart, the mobile simulation cart project that we are working on is to do exactly this, is to say, let's identify, and this is being championed by Dr. Masimbi, let's identify, the top few hospitals in the country that have the highest, this is just an example, right? This is not exactly what we're going to do, but identify the few hospitals in the country that have the highest rates of C-section and
Mhm.
say, we are going to put a mobile simulation cart into those three hospitals. We're going to do team trainings around operative vaginal delivery for those three sites for once a week for 3 months, right? And they're going to be like There's going to be a pre-session. We're going to identify champions. Those champions are then going to run a session every week out on site. We'll have virtual mentorship. And then we're going to look at the outcomes of those C-section rates on those sites and say, technically, our expectation would be if we improved operative vaginal delivery, so forceps and vacuum, we should see decreasing C-section rates.
Mhm.
And that is overall a good thing, right? And it should be cost saving. So that's just one example, but I think the more focused we can get about our actual simulation interventions and decreasing the amount of noise between the intervention and the outcome, the better. It's just really hard with like how much goes into determination of patient outcomes.
It's okay.
Thank you. Thank you. Any other question? So I can ask my third question.
I think there's one in the chat, and I think it's sort of similar, I guess,
Ah,
to Dr. Mohammed's
I
question, but
can't see.
it says, how do you manage the lack of
Ah,
is that SPs?
we did.
It's uh, it's
We
a little
did.
bit like my questions about the use
Yeah,
of the SP in pediatric scenario.
yeah, yeah.
So
I
go
guess
ahead, Noor, for your question.
the
Yes. I just wanted to ask if you have any experience on simulation on children, sick children. I saw a program for children who has autism, and they train them to go to the doctor, to have the blood sampling, to have the CT scans, and now we're seeing more and more, and we would like to, when we we will improve to add this activity to teach children, to make them in some situations. Do you have any experience to share with us?
Yeah, so my area of work has not overlapped a lot with you know, developmental disabilities or autism or other areas such as that. But I think a lot of the work that is being done at Boston Children's to try and desensitize patients to procedures is especially for some of our patients who are much more sensitive to things like that. And so patients with autism obviously have a lot of sensory sensitivities. And we have, I think the Boston Children's Immersive Design System team has worked really closely with our experts in child life to bring patients in before their necessary preoperative visit in order to do that sort of desensitization. So I think it's becoming pretty accepted that that is a benefit for the patients and for the parents as well, just given that it's quite traumatizing to watch your child be in distress. Um, I think the challenge there is that that's obviously a pretty, it takes a good amount of resources to make something like that happen, right? To sort of have people come in additionally preoperatively. They're already very busy coming in for all the necessary preoperative visits for, whatever testing they need and meeting with the anesthesiologist. So I think if your site has the resources to sort of add that into the preoperative requirements, I would absolutely recommend doing it. I don't personally have a ton of experience building curricula around that, but I think, I would definitely lean on sort of child life experts, or child psychologists as sort of the experts in helping with that.
Thank you for your answer. We have a question in the chat from Yamama, Professor Yamama Ammar, who says, thanks to your great presentation, what is the place of teaching soft skills to medical students, especially in the field of pediatrics?
Yeah. So this is definitely an area that our clinical pediatrics team has been very interested in. And I think particularly around how to break bad news, how to talk with parents about challenging conversations, how to disclose concerns around child abuse. So I think this is definitely something that comes up in pediatrics uniquely. And Dr. Masimbi and her team, as well as a visiting fellow for the year, actually developed a non-technical skills training program that they rolled out this year at UGHE that I think has been met with a lot of positive feedback. So it's definitely an area that we feel very passionate about, and I think we could probably try and connect you with the team that worked on that if you'd be more interested in learning details.
So thank you very much. We started to do that, but just with the level one. That means how to deal with the newborn, how to deal with the infant and different ages, and how to talk to a child, because most of them don't know really how to deal to manage a child. Of course, with the parents, but I think we should start to talk to the child. And I'm a pediatrician, and I talk all with babies too, with newborns too, because for me it's important to tell them what you're doing, even if we don't know if they understand. So thank you for
Absolutely.
your answer. Is there any other questions?
There's one more in the chat.
One more
Are there
question in the chat, no?
In the chat, I can see
Miriam, yeah.
Dr. Alami. Are there standardized simulation-based curricula specially designed for pediatric surgery training?
That's a great question. I don't know. I'm sure there are some resources. I don't know off the top of my head what they are. I could look into them a little bit more. I know that there's a handful of different universities and or nonprofits working on developing some standardized trainings in general for surgical skills. And I think some of those skills include pediatric surgery training. I'm not sure if there's any specifically developed, around like full curriculum just around pediatric surgery. So I think a couple good resources to turn to for that might be just COSEXA in general. Ha probably some of the most up-to-date resources on that. And then we have been working with I'm gonna blank on the name of it right now. I can't remember the name of the group right now. They're working to sort of create like um, a a catalog of self-paced surgical skills that surgeons can use, and I think part of that includes pediatrics. But once again, it's not a specific pediatric focus.
Okay, thank you very much. Donc, Dr. Fahedi asked, thank you for this valuable webinar. Can you share with us your experience about teaching communication to med students and nurse students, especially with parents and children?
Yeah. I mean, I think I actually I one of my most meaningful lectures that I received as a medical student was from an emergency medicine doctor at Boston Children's Hospital who showed us multiple videos of him interacting with children. And I think, as Dr. Noor, you were saying the just how you talk to kids and how you approach them and the body language and every way, everything that you do can really change the encounter from when you walk in the door. And so I think that we actually don't do a ton of simulation-based casework around that, but I think it comes up as people are doing bedside teaching more in pediatrics. But I think that the more that we sort of can recognize the importance of teaching that because sometimes it just doesn't come easily. Some people it comes easily too, especially if you have really little siblings or you're around a lot of nephews or small babies that you sort of understand kids. But I think just teaching some of the importance of body language and nonverbal cues is really critical. It's just not something that we've sort of formally done a lot in our pediatric training.
Dr. Siku has a question. We're waiting for the questions by the chat. Can I ask you a question before she writes her question? It's about AI plus feedback. You talked about surgery. Can we do it with the pediatric scenarios? Since it's difficult to have simulate patients, can we put, and we have auto feedback for, not
Yeah,
feedback made by a person, but by the AI.
yeah. So a handful of so you're talking about the like XR VR, not the
Yes.
like cameras installed cameras installed in the OR thing is actually something that's being done in both adult and pediatric surgery. So that's sort of agnostic to pediatrics, and it's something that's happening at Boston Children's Hospital right now. But in terms of VR headsets, that really comes down to the limitation there is software. So, I think there's a handful of different companies that are developing pretty good software. One of them is called Health Scholars. Another one is called SimX. I can put those in the chat. Health Scholars, SimX, OMS. And each of them has a little bit of a different flavor. In terms of what kind of experience they offer. SimX requires an instructor to be with you at all times. So I might be standing in front of someone who has a headset on. I have an iPad. I can control what they're seeing, what they're hearing. I can control everything in real time based on the responses that they are giving me or the things that they're doing in the case. Um, OMS is like completely opposite. It's a little bit more focused on like personal skill development. So you might go into a case, it's really about like taking the right history, developing your right differential, ordering the right tests. But it's a little bit less realistic. Like you have to click into each of the things rather than talk to it, or it's not as smooth of a process, but it's quite detailed. And there's a handful of cases in the library, both for adults and pediatrics and emergency and OBGYN. Um, Health Scholars is a little bit in the middle. It's still an independent case, but you can talk to it, so it feels a little bit more realistic. And they have a smaller library than OMS, so it's not as large of a breadth, but they have some pediatrics cases, some adult cases, mostly focused around emergencies. Um, and I think they have a couple cases for obstetrics as well. And
Okay,
that's honestly just three of many that I have sort of experience with, but there are many others that are out there.
okay, thank you. I think one last question from Khadija Siku. Any experience about interpro simulation-based curricula in managing palatal cleft?
Yeah. I don't personally have a lot of experience in interprofessional simulation around cleft palate specifically, but I think simulation is a great tool for bringing those teams together. I think oftentimes with Project Smile or other cleft palate repair groups, they come into situations usually as a full team, so they've already done a lot of team training together. But I think if you're working at an institution where that team is then trying to do team training for a team locally, doing that in simulation is actually a great method to do it within. Um, so would be a big proponent of that.
Thank you. Any other question?
No,
Oui,
yeah,
Professor Howie.
yeah, of course. So, Chris, thank you very much. Another question from my part. Uh, I really appreciate the fact that you have been talking about XR, extended reality. Uh, my question is, and my little concern about this, are there validated XR-based tools or something like studies that show, let me say that show improved learning or clinical outcomes when using extended reality for pediatric training scenarios?
Yeah, I think it's a great question, and I think similar the to the question on how can we really ensure that we're proving outcomes, we're just not there yet, I think, especially just around pediatrics. I'm sure there's some literature that I don't have off the top of my head that shows some positive impact with XR and just general cases. I'm not sure specifically to pediatrics, but I would imagine that we are really close to proving that when it takes. I think XR is just about to explode, and especially XR in the clinical education space.
Okay, thank you.
Yeah.
Thank you very much. Any other questions?
Mhm.
No? I think it was very clear, and we asked all the question we wanted to ask. So I think we're close to the end of our time. So on behalf of Morocco Sim and all participants, I want sincerely to thank you, Dr. Callahan, for sharing your time, experience, and wisdom. Special thank you as well to us, to our audience for your engagement and the thoughtful question. I think we all learned a lot of things today from your experience, and it reinforced the importance of pediatric simulation in building safer healthcare system. I think it's time to say goodbye. So stay safe and keep innovating. And thank you again so much, Chris. It was a real pleasure. Thank you.
Thank you all. The pleasure was mine.
No, thank you very much, Chris. Thank you once again. Thank you for this very insightful presentation. Thank you to you, Noor, for the chairwoman, for the
Thank
excellent moderation. This was really a truly valuable session. It
Thank
was
you.
at the same time both inspiring and thought-provoking. Grateful, very grateful to you, both of you, and to the audience. And let's meet for the next webinar next month. And we will have pleasure to welcome Mr. Professor Jared, which is the head of SSH, inshallah. So see you soon and bye-bye. Thank you, Chris.
Bye. Thank you, Chris.
Thank you.